Hello. Today we're going to be talking about causes of syncope on ECGs, and the only way not to miss the killers. Well, the thing is, you get this lady who fainted for 10 seconds in the supermarket, and now they feel fine. The vitals are normal, no problems there. The ECG might look fine, and that becomes a problem because a normal ECG does not mean that things are fine, that you can relax yet. So I always like to say, where are you? Wherever you are will determine how far you would go in terms of, what you do for the patient. If you are in the community, let's say you're a family practitioner or general practitioner, you the best you might be able to do are vitals. And if the patient has told you, oh, they feel better now, you might be tempted to send them home. But depending on the story, as we will find out today, don't send them home. You might be in the ED and you're asked to sign off an ECG. The ECG looks normal, or even the patient wants to go home. What will you tell this patient? Given what you know about what you will learn today about syncope or collapses in patients with a normal ECG. Well, we're going to discuss this ECG. Stay tuned. We're going to break this down for you. And I know some of you can already see what is wrong with this ECG. You're already pointing out abnormalities. But for those who want to know the final diagnosis of this ECG, or who just need a little help in breaking down an ECG to tease out what is abnormal, we're going to be coming back to this at the end of this short chat. We've talked about the reassurance trap already. They tell you no chest pain, or I feel better now. I must have not really, I don't know what happened. Maybe I did not have enough food to eat. But their glucose was fine, or they're telling you some very non specific story that doesn't quite add up. Or they're still looking gray uphill, even though, the ECG is normal. That can be a reassurance trap. And the question is not is this ECG normal? Is this ECG a STEMI? The question is this art coping right now with the physiology? And so there's a way to go about it. There are non-cardiac causes of syncope and there are cardiac causes of syncope. Of course, one major reason you're doing ECGs is to rule out the cardiac causes of syncope. And the ECG might also be able to give you clues about the non cardiac causes of a collapse. So it's really important that you pay attention here. Now, one thing you need to ask yourself is, did they fully lose consciousness or did they feel faint? We all know, especially in the elderly, especially in hot weather, they might just faint, because if it is true syncope, your ECG is no longer optional. Now your ECG becomes a medical legal life insurance. And I don't care about pretty waveforms yet. I care about, why did the brain lose blood? Why did the brain shut down even for a few seconds or few minutes, right? So you think of the rate and the rhythm, and that's why we're talking about arrhythmia here. If they're having bradyarrhythmias, for example, a complete heart block or high-grade atrioventricular block or sinus pulses or six sinus syndrome, you might have, a cause for the syncope on ECG, right? Because these symptoms, however, you should know, may be present or completely absent on an ECG. You also have tachyarrhythmias, ventricular tachycardia. Those are your wide complex tachycardias, your narrow complex tachycardias, your AF. Now, now, you would know a tachyarrhythmia on an ECG. You will know a bradyarrhythmia on an ECG. If you do not know, subscribe to our page. We're going to be breaking out all of these topics one by one on our YouTube and on our Instagrams. But you should be able to know, if you give yourself or you arm yourself with enough knowledge to know about the bradyarrhythmias, the tachyarrhythmias, what are the features. For example, you know that your heart blocks might have, if it's a first degree, might have prolonged PR interval. Your second degree heart blocks can be Weckenbach or Mobit 2. Your complete heart block might be when your atrium is not having a steady relationship with the ventricles, and that's what we call atrioventricular dissociation. Also, you know about your tachyarrhythmias, where you will have your ventricular tachycardia, which are quite organized compared to ventricular fibrillation. And what you're having is a wide complex one. You know the history, right? So my point here on this slide is, you know the obvious causes. You should know the obvious causes or the obvious characteristics of a tachyarrhythmia or a bradyarrhythmia, or even intermittent channelopathies. For example, your long QT syndromes, your Brugada pattern. You're seeing a young patient who has collapsed and now feels well now. You should go, if you don't, go on our page. And if you need help identifying any of these ECGs, because right now they don't have the titles in front of them, do let us know, right? And we will be able to point that out to you. We are working on titling the ECGs better. But the pre-excitation ECGs, like your Wolff-Parkinson-White syndrome, right? You should be able to identify those. This, in Wolff-Parkinson-White, they would have a delta wave, a shortened PR interval, a widened QRS. You should, to be fair, those things need devoting some time and effort into, and we've made learning these topics easier on our page. But you know arrhythmias don't need to be present to kill. That's the trouble with all of these things. Sometimes they evolve, sometimes they're not present on your ECG, and they just need to have happened. They might have happened for maybe the 5 seconds or 10 seconds that the patient experienced the collapse. And here you are trying to work up this patient, and this ECG is absolutely normal. I'll tell you what to do. We will run through what to do in those instances. Now, is there a structural heart disease? We're still looking at cardiology causes here. For example, aortic stenosis, hypertrophic cardiomyopathy, dilated cardiomyopathy, previous MIs with a scar-related ventricular tachycardia. And the clues you will have here would be, for example, you will see features of LVH with strain, pathological Q waves, poor R progression, and conduction diseases. Now, it could also be ischemic changes. For example, your ACS, demand ischemia, inferior MI affecting the atrioventricular node. Think of it. If you have inferior MI that is affecting the atrioventricular node, what will you have? You might have blocks. You might have, a first degree heart block, even though we say first degree heart blocks are many times benign. But if there's ischemia ongoing, that might be your first pointer. So you have a completely fine looking ECG that does not have an ST elevation or ST depression, and the first signs might just be a prolonged PR interval. Isn't that crazy? You'd have new T wave inversion, or you could have a heart block, and that could be your first, or your initial clues. Now, the next step you will need to do in all of these cases is, if this patient is sufficiently symptomatic, right? If you're thinking heart block, you're thinking ventricular disease, you're thinking ST segment, you need to not be crazy about sending the patient away, no matter the pressures you are facing in terms of hospital beds or colleagues and needing the bed and the rest. You need to be systematic and observe the patient. Keep the patient in the department. Don't take the ECG lids off. Do serial ECGs, right? Do serial ECGs, admit, ask a senior to review if you're not the most senior there. Do not discharge on just a normal ECG. Make sure you've walked them up. Now, think non-cardiac, right? We've talked about cardiac, we've talked about um, thinking structural or malignant arrhythmia. Is the QRS greater than 120 milliseconds? Is there left bundle branch block in syncope? Is there a right bundle branch block with axis deviation? Is there a bifascicular block, in which case you will have a prolonged PR interval, and the level of conduction block is occurring at the is at the level of the east, right? At the level of the HIS, and then, sorry, the word is not coming to me, but is it occurring infranodally, right? Um, ST segment. So the non-cardiac causes are the things that you should not miss, right? The non-cardiac causes can be a vasovagal trigger. It can be triggered by pain, stress standing. And the reason why you should not miss this is that they might not be potentially as dangerous as the cardiac causes. But it's just good to know, so that you can safely assure or reassure a patient and safely plan follow-up. The ECG is usually normal. For example, you're taking blood from a patient, and that can be triggered by pain, by stress, by standing. Sometimes micturition, they're going to have a wee, and the moment they have a wee, because of the cardiac output, because of a surge, in cardiac output from postural hypotension, what you have there is a syncope, and it could be through medications as well. For example, we know that beta blockers and even your alpha blockers can cause a lot of dizziness and postural hypotension. Volume depletion, have they been having a lot of diarrhea or have they lost blood? And so what you could have here is just a normal ECG or even sinus tachycardia. Non-cardiac causes, we've mentioned this. So the real life principle is a normal ECG will not rule out a dangerous cause of syncope. What increases risk regardless of ECG are these things. Now, this is the highlight for me. Is the syncope occurring at rest, or is it when lying flat? Was there a prodrome? When we mean prodrome, for example, did they get some aura, some lightheadedness? Did they feel off, dizzy before the syncope occurred? So if they have a prodrome, that is a good thing. If they did not have a prodrome, then that risk, this is a red flag. Did they have exertional syncope? Was this syncope occurring when they tried to do something a little bit, strenuous for them? Like maybe it occur while they were trying to walk up a hill or even do a little bit of jogging? Is there a known heart disease in this patient? Is there a family history of sudden death that increases your risk? Right? And now, this is the flow chart that summarizes all the things we've said. If there's syncope and you are doing an ECG, ask yourself, right? And this is what I've been trying to explain, right? Ask yourself, did it occur during exertion or while lying flat? If it's while lying flat or during exertion, that is a red flag. Was there a prodrome or was it just sudden without any warning? If it's without warning, that's a red flag. Is there a known heart disease? Is there family history of sudden cardiac death? If there's a family history of sudden cardiac death, what are you thinking of? There's so many things to think of, especially if they're young, they are Southeast Asian, they are males, you Brugada, your ARVD, you know, and so many other things, right? You want to really, really dig out, and make sure this person has some extensive follow up and cardiac follow up, or you even want to admit in the department, depending, and you want to get cardiology involved. Many of these things are often about saving lives and also about covering yourself, but saving lives should be the top of your priority, because you wouldn't like a situation where you were the one who saw your patient last before they and you didn't do everything you could do, or you did not do the right things, or you were criticized. No, it's okay to be criticized, but how would you feel if you did not do your best for a patient and they died? It becomes, I mean, it's one of the things that you might not really easily recover from, right? So you look at the ECG, that's step 2 in this flow chart. Is the rhythm abnormal? Is there bradycardia? Are there pulses? Is there AV block? What are the QRS complexes doing? Is there a P wave following a QRS? If there's no P wave, is that an AF with a fast rate? If yes, if they are rhythmic, the syncope, syncope is likely. Now, is the conduction disease present? For example, is there a bundle branch block? Is there a prolonged PR interval? Is there a fascicular block? If yes, intermittent high-grade block possible, right? Are there ischemic changes? Is there ST elevation, depression? Is there a new T-wave inversion? Are there inferior changes suggesting AV nodal involvement? If yes, you're looking at an ischemic syncope. If the ECG is normal, do not stop, right? Orthostatic blood pressure drop or postural hypotension may be possible. Infection, anemia, dehydration can cause reflex or demand causes, and you still may need to resuscitate them with fluids. You may still need to find a clear trigger. Look at the electrolytes. Look at the entire picture. Right? If there's a clear trigger plus a prodrome, then that is a vasovagal, and you might be okay to discharge them after giving some fluids. But if there's no clear trigger and there is no prodrome, decide what the next step is, right? Because if it is a low risk and a clear benign cause, you want to reassure and safety net. But if it is unclear, or their recurrent symptoms, you might want to send them with an Holter monitor. But if the high risk features are present despite a normal ECG, you want to admit or get an urgent cardiology opinion. Now, I wanted us to go through that ECG we did. This ECG, this patient was a middle aged patient, never had heart issues, presented with a sudden collapse without any warning, and an ECG was done. This ECG, obviously, if you go through the 5-step method, there are a few red flags on this ECG. The rate looks a bit normalish. Is permit me to speak. So let's count the number of big boxes: one, two, three, four, five, six. So yeah, you could say maybe a little bit of bradycardia is going on here, and the rhythm was, you can see a P wave before every QRS wave. There's a bit of a T wave inversion in 2 and in 3, and also, yes, in 2 and in 3 at least. But also the P waves are not looking like the correct morphology. The axis looks normal. The QRS intervals, yeah, they're quite narrow. But what else do you find? You find what looks like an ST elevation in V1, V2, V3, V4. But bear it in mind that that's not the major thing. There's something else that's causing the ST wave elevation, not necessarily ischemic changes here. What you'll find here is that your S in V1 and your R in V5. So your S in V1, V2, V3, compare it with your R in V5, V6. If you've heard of the Sokolo-Lyon criteria, this will be shouting loudly to you, because it's the criteria. One of the criteria is that your S in V1 and your R in V5, if you add the big boxes, or if you add it, there should not be more than 7 big boxes, or 30, or 35 small boxes, right? And so this is clearly exceeding that criteria and is pointing to a left ventricular hypertrophy. Now, this is not where it ends. Clinically, this patient, when this patient was examined, this patient had murmurs, and so an echo was done, which proved aortic stenosis in this patient. So let's think of areas where this diagnosis could have been missed, because this patient was admitted and at the end of the day had to have TAVI done, because this was quite discovered to be some moderate to severe aortic stenosis. So areas where people could have missed this diagnosis, and this patient could have gone on, left the department and died, is firstly, was this ECG interpreted well? Was this patient listened to? For example, for instance, this particular patient did present with no warning signs. No warning signs, no prodrome, just a sudden collapse. So, did you take a good history in this patient? Did you do an ECG? And if you did this ECG, did you interpret this ECG correctly? Did you look at other bloods? Of course, bloods might not have given us much in this patient, but obviously, did you do other bloods? And did you look at the entire clinical picture? Now, given that this ECG was interpreted properly, well, somebody could have said, oh, well, maybe you've had some long-standing hypertension, nothing to do, go back to your GP, go back to go back to the community and let them, check this for you. Your BP is only slightly elevated. But somebody, a good clinician listened to this patient and was able to pick up a murmur and was able to, characterize the murmur and said, well, something is going on here. This could be aortic stenosis, given this type of ash murmur. But they took it further, called in cardiology, was able to get an echo done, admit the patient, and give this patient life-saving management. So this is just an example of when an ECG looks a bit organized. Patient is looking not too bad, but high risk features were present, and the diagnosis was dug out. I hope you enjoyed this session. Stick around, subscribe to our YouTube page, follow us on our Instagram so that you can get more of these short bites.